Good afternoon. Welcome to the second session of the 2014 webinar series on geriatric emergency preparedness provided by the GIPR Collaborative. The collaborative was formed in 2004 when 6 HRSA-funded GECs, listed on the next 2 slides, received seed grants to provide preparedness training for healthcare providers who serve older adults in healthcare and social service settings. Initially called the Bioterrorism Preparedness in Aging, the name shifted to GIPR Collaborative as they developed interprofessional training for health professionals. The goal is to continue educating and developing resources to enable older adults, especially the at-risk elders and their caregivers, to make decisions about being safe before, during, and after all types of disasters. In 2010, 3 collaborative members listed on this slide formed a national consortium to provide a GIPR webinar series. The consortium has provided 11 webinars, and this session will be followed by a webinar on June 11, 12 to 1 p.m. Pacific Time about the active shooter in long-term care and assisted living facilities. You are welcome to register for this cost-free webinar. Our speaker is Ms. Elizabeth Shields. She is the Institutional Director of the GEC at the University of Louisville that is part of the Ohio Valley Appalachia Region GEC in the University of Kentucky. I shall highlight some of Betty's activities and accomplishments. She has years of experience working with Kentucky long-term care for the western half of the state and is the principal investigator for a project funded by the Kentucky Department for Public Health. She gives presentations on preparedness for vulnerable populations and has developed resources such as the Kentucky All Hazards Long-Term Care Planning and Resource Manual, designated as a 2010 National Best Practice Guide by the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Preparedness and Response. She serves on national boards, and recently she was appointed chair for the Disaster and Aging Interest Group of the Gerontological Society of America. Betty will talk about navigating the maze of guidelines and requirements for preparedness in long-term care settings. Thank you, Betty, for joining us.
Thanks, Malin. This afternoon, I'm going to talk about navigating the maze of guidelines and requirements for preparedness in long-term care settings. Our objectives this afternoon include identifying key stakeholders and partners who we have found it is critical to work with to pursue effective preparedness planning. We're going to address the new CMS emergency preparedness proposed ruling that came out in December that may turn into regulation later in the year, and also look at surge planning by assessing the immediate long-term care bed availability and assess the gap between what hospitals expect in a surge response from long-term care and what capacity is actually available during a disaster. Additional objectives include assessing state resources for mass casualty and surge planning, identifying key partners to be able to carry that out effectively, and ways to overcome barriers to effective preparedness, especially in no-notice disasters. And this is a critical element. I'm speaking from Louisville, Kentucky, and we fall into that middle part of the country where we do not have advance notice of a disaster. In a best case, we might find out the night before that an ice storm could be coming into the state anytime in the next 12 hours, and long-term care facilities might ask a shift of staff to spend the night in order to be available the next day. On the whole, we get about 13 minutes notice of a disaster, and that's in the case of a tornado. And we don't exactly know where the location of the tornado is going to be until that 13-minute window. So we may know in advance a couple of hours. However, we're not able to anticipate impact and to begin to evacuate, et cetera, as many locations can in the hurricane states, in those coastal states around the country. So our response is somewhat different because we don't have advance notice. And then identify cross benefits from statewide aging collaborations that result in additional funding opportunities. Our Kentucky preparedness efforts related to long-term care started about 7-8 years ago when the state came to the Universities of Kentucky and University of Louisville to ask us to expand our efforts working with community-based agencies in their emergency preparedness to tackle long-term care preparedness. This was prior to Hurricane Katrina and after 9/11. Out of that effort, we established the Kentucky Emergency Preparedness for Aging program and added long-term care onto that about 7 years ago. The program's efforts are in collaboration with the Kentucky Healthcare Preparedness Coalitions across the state that are funded as hospital preparedness regions under DHHS. Key stakeholders and partners in the coalitions and as part of our program partners include the Kentucky Department for Public Health, the 2 long-term care state associations, the Kentucky Hospital Association, the Kentucky Division of Emergency Management at the state level, Kentucky Long-Term Care Ombudsman Program, the American Red Cross, both at the state level and at local levels, and Emergency Support Function 8 under FEMA, and then under the Department for Public Health at the state level. This is a map of Kentucky broken into 15 hospital preparedness regions. These regions have been in functional coalitions since just around 9/11, if not a little bit prior to 9/11. And you can see the representation across the state, and you also will see within those regions a whole lot of counties. And that's significant because Kentucky has more counties than any state in the country. We have 120 counties. And that means that we have 120 jurisdictions. We have 120 local emergency managers who are appointed by their county judges or mayors. Those emergency managers can be full paid, they can be part-time, they can be volunteer, and they do not necessarily have to have prior experience with emergency preparedness or emergency response. At the state level, under the Kentucky Division for Emergency Preparedness, there are regional managers who also work in conjunction with the local managers, but the Kentucky Division for Emergency Management is part of the state government and is part of the Department for Military Affairs. Another element to consider with this slide is not only the numbers of counties and numbers of regions, but also the fact that driving from one end of the state to the other can take 7 to 8 hours. That's significant, especially as we talk about surge, because it may take numbers of counties to respond to one long-term care facility evacuation. And should we have regional evacuations, it could take major portions of the state. And that would take multiple strike teams of emergency medical services, as well as private transportation vendors, moving across from the eastern and western parts of the state in towards the middle, or moving from the middle outwards. Quite a lengthy and involved process. Fortunately, we haven't had to practice that one yet in terms of a real life experience. However, given some of the scenarios I'm going to talk about, you may appreciate the impact of the scope of that. In December of 2013, CMS issued in the Federal Register a document entitled Emergency Preparedness Requirements for Medicare and Medicaid Participating Providers and Suppliers. This document represents the first major initiative of CMS to actually put into regulation emergency preparedness requirements across healthcare facilities, whether it's hospitals, long-term care, home health corporations, hospice entities, dialysis centers, et cetera. And they're applying a large number of the regulations, potential regulations, across that broad spectrum of healthcare facilities. The requirements posted in that ruling arise out of a conclusion drawn that's incorporated in the executive summary of the document, that current emergency preparedness regulatory requirements are not comprehensive enough to address the complexities of actual emergencies. Number one, they find that healthcare providers are not prepared to protect the safety and health of persons they're responsible for. And secondly, that there exist inconsistent regulatory approaches across agencies and jurisdictions. Most of you already appreciate that latter one. The conclusions drawn in this proposed ruling are based on a series of research studies that have been executed and published since 9/11 and take into consideration the lessons learned from 9/11, from hurricanes Katrina, followed by Rita, most recently culminating in Hurricane Sandy. I've included on this slide a link to that proposed ruling. And among the requirements in the ruling is that each long-term care facility have a surge plan for medical surge and for community surge. Surge occurs when healthcare facilities need to evacuate to other healthcare facilities. Community surge is when neighbors in a certain type of an emergency event might seek sheltering at a long-term care facility. Triggering events for surge include the need for immediate hosting of persons, whether it's long-term care or hospitals needing to evacuate to long-term care due to a fire or another specific type of an event, or if there's a regional event resulting in multiple facility evacuations, such as the historic Ohio River flood of approximately 5 years ago, where a number of facilities or hospitals were very close to evacuating and would have needed to evacuate out of the region. Also, a triggering event can be when infrastructure and transportation routes get in the way of effective evacuation, and a facility may need to go to the closest place possible, regardless of that facility's capacity to absorb them. And then lastly, transportation resources may be limited, where emergency medical services resources are overwhelmed and transportation over extended distances are impractical. Now, we take that into consideration again as a no-notice event type of a state. In an advance notice state, you may have vendor agreements with transportation vendors where they may have 3 to 4 days advance notice to evacuate a long-term care facility or a hospital to like types of facilities outside of the region, potentially even outside of the state. That doesn't happen in a no-notice event. And in that case, you simply use the resources that are available, and it may be very limited in terms of ambulance transportation, school bus transportation vans, and as well as access to and from your vendors. Another reason surge is important to Kentucky is that bullseye in the middle of the map of the United States on this slide. What you see in that pink area in the bullseye is the major impact zone in the event of a major earthquake at the New Madrid Fault. In the peach and yellow to the darker blue section you have significant impacts experienced through the lighter blue, where the impact may be felt between the Colorado Rockies and the coastal Atlantic states. The estimate of the population impacted by a major earthquake at the New Madrid Fault is greater than the population of the entire state of California. And the reason for that is in California, in the event of a major earthquake, the Sierra Mountains serve to absorb a lot of that energy source that comes with an earthquake. And the earthquake tends not to get beyond the Sierras. In the middle part of the country, you don't have mountains until you hit the Colorado Rockies to your west, and then you have some impact and protection from the Alleghenies in the east, but not significantly so. In the last major earthquake at the New Madrid Fault, approximately 200 years ago, church bells chimed in Boston, Massachusetts from the impact of the earthquake that affected St. Louis, far western Kentucky, Memphis, down into Tennessee, Illinois, Indiana, as well as Kentucky. Immediate surge need is an issue that has come up in the last few years as the hospital entities and their preparedness have looked to long-term care to be a source of a receiving sites for discharged patients during a disaster that affects a hospital or a location. Meaning, if new injured come in, they are surging into a hospital, and the hospital may need to discharge their less acute patients to other types of healthcare facilities in order to handle and to have the capacity available for the newly injured. They oftentimes, in their preparedness literature, look to long-term care. That's one of the major issues we have addressed in Kentucky. Another case of immediate surge need is when a long-term care facility needs to evacuate immediately and needs a response from other long-term care. In 2012, the Hospital Preparedness Program established medical surge capability performance measures, and included in those measures was a target for a hospital coalition or a regional coalition to be able to provide no less than 20% bed availability for staffed members' beds within 4 hours of a disaster. What does that mean? It means that if a hospital needed to discharge up to 20% of their patients in order to absorb newly injured, they would want to be able to place that 20% of patient base within 4 hours in like types of healthcare facilities. We think of that in terms of medical surge. And the topic of medical surge is the ability to provide adequate medical evaluation and care in events that severely challenge or exceed the normal medical infrastructure of an affected community, either through the numbers of patients being surged out or discharged out, or the types of patients being discharged out or surged out and then received on the other side of the equation. We did an assessment of Kentucky's hospital immediate surge from the perspective of long-term care, and we found in the bottom row of this table that 20% hospital surge would be the equivalent of 1,317 patients to be discharged. The available beds across long-term care on any given day under that scenario would be 2,581 beds. Therefore, there is an excess of beds from long-term care to receive hospital discharged patients. That's a good scenario until we look at the number of facilities that would involve. And that would involve 285 long-term care across the state in all 120 counties, which have on average 9 available beds per day. That would not meet the requirement to be able to manage that surge and to receive that surge within 4 hours, much less have the transportation capacity available, no matter where the event site was. So when we look at long-term care surge planning, we look at the effect of the CMS proposed ruling on the need for surge planning. We look at the constant need for immediate long-term care bed availability to be able to have immediate response to a surge situation. We look at the gap between what hospitals and long-term care need and what capacity is available during a disaster, especially to meet that time frame target of 4 hours. In that, we're looking at long-term care to long-term care evacuation support, hospitals' need for long-term care to respond, and the issue of the number of available beds in Kentucky long-term care on any given day. Barriers to surge planning to date have been, number one, insufficient long-term care open beds to be able to absorb a major surge from another long-term care facility, barriers to preparedness at the long-term care level, especially in a no-notice event. We find that many long-term care have not completed their hazard vulnerability analysis. They have not identified their facility risks from the top 3 hazards that they may be exposed to, and CMS requirements versus the needs at the state level to be able to house or host evacuees. We view surge planning as a process. It really is about pre-planning. It starts at the pre-planning, and the better the pre-planning, the better chance of successful surge response. Number one, it's important to pre-plan your facility surge capacity. How many folks you could literally take in should you get that call in the middle of third shift to receive evacuees, and to plan facility capacity to receive evacuees in advance of a request to host those evacuees. Number two, consider the scope of surge that your facility is open to negotiating the day or night that that call comes in. In an ideal world, there's only one event happening in a state or in a region, in a county, and you can call another long-term care with whom you have a memorandum of agreement and say, I need you to receive some of my residents and to house them over a short time. Well, this past winter, we learned that those kinds of calls would have been very difficult to respond to because of the severe winter weather that we experienced, with major water main breaks, major leaks within long-term care facilities. We actually had water companies in rural areas of the state whose pumps froze during the severe cold this winter, and regions were literally without water for periods of time. In one case, we had a facility that was operational, but they had no potable or non-potable water for about a day and a half. And they had to get response from the state to send in water, as well as response from neighbors and other long-term care to help out. That facility had open beds, it had staff, but it didn't have the facility resources at full tilt to be able to respond. Also, we want to review the key issues of concern to the licensing entity. And in Kentucky, that's our Office of Inspector General at the Cabinet for Health and Family Services at the state level. We are part of Region 4 of CMS jurisdiction, and that region does not support pre-approval of expansive surge capacity beyond authorized licensed beds, so that we cannot have implicit guidance and waivers in place in advance of an ability to respond to the need to receive surge. Therefore, the approach that we're recommending is a pre-planning approach, whereby the facility is able to know what bed levels you have for different types of surge. You know what the stability of the facility is in order to make a decision what level of surge response you're willing to receive, which puts you in a position to negotiate a final surge agreement with a sending facility based on actual information and good estimates. The facility can be clear about exactly what resources the sending facility will provide as you're negotiating that final surge agreement. If the receiving site needs additional resources in order to respond, you'd have time to contact your local emergency manager, and then notify your state licensing agency once both the sending and the receiving sites have completed your surge agreement, so that your licensing entity would know the rationale and possibly have the evidence attached to justify your decision to receive evacuees. You want to be clear about your objective. Medical surge is different from community surge. In Kentucky, the Red Cross at the state level has a contract with the state to be responsible for establishing shelters, so that in the event of a significant emergency where entire neighborhoods would need sheltering, the local emergency manager would already have established their mechanisms by which to contact the Red Cross. So the guidance in the proposed ruling from CMS to establish a surge plan for community surge, at least for Kentucky, relates more to advanced notice events than it does to no notice events, and we would look to the Red Cross. Also, you want to have mutual aid agreements or MOAs, MOUs with hospitals and other long-term care facilities that you would want to surge to, as well as agree to be a source of hosting should those facilities need to evacuate. The solution for surge planning that we have recommended to Kentucky Long-Term Care include the 3 levels of medical surge. And those 3 levels are conventional surge, contingency surge, and crisis surge. Conventional surge is where you basically fill your existing available beds, and you would host a long-term care facility's evacuees for up to 3 days in your open available beds. This situation would not put a significant stress on the receiving site, and normal operations would be able to continue, especially in the event that the sending facility sends staff, medical records, medications, resident charts, and any special equipment for a resident. This requires notification to the licensing entity at the state once all of that's been agreed on, and keep in mind that you would not be admitting new residents, you would be hosting evacuees. In conventional surge, you want to keep in mind that you will always follow life safety guidelines. Ideally, in your plan, you would identify available beds in advance that could be used for short-term hosting. Do not consider beds that are being held for a confirmed admission. Identify available beds by gender, level of care, and payer source. And when that call comes in on the 3rd shift from an evacuating long-term care facility to your 3rd shift staff and says, we need to be sending you some evacuees, how many beds can you fill? Whoever staff might be who'd answer that phone call, the facility on the receiving end would want to know the types of evacuees you're not willing to receive, such as ventilator evacuees, etc. Contingency surge is when additional bed capacity is created by converting single rooms to doubles and doubles to triple, keeping in mind your life safety guidelines. You want to consider room size guidelines. Realize that contingency surge creates stress on the daily provision of care and resources in the receiving facility. It becomes critical with contingency surge that the sending facility send all the needed resources in order to care for their residents in a hosting situation at a facility. And also, this is a likely case where the receiving site would want to contact your county emergency manager and regional healthcare preparedness program staff for assistance with beds, cots, linens, etc. Crisis surge is when you've already filled your available beds, you've turned as many singles into doubles and doubles into triples as life safety guidelines will allow. And now we're looking at a true crisis situation where you're considering putting in additional bed capacity using cots or beds or mattresses on the floor in certain cases in your non-sleeping areas. Again, keeping in mind your life safety guidelines. You want to assess your bed capacity in non-sleeping areas well in advance of these calls ever coming in. A crisis surge will indeed create stress on the provision of care, and you may even need to implement crisis standards of care. There will most likely be a significant need for resources from the sending facility, as well as emergency management from the county and the regional and potentially the state level, as well as from the hospital preparedness program. How do you do space assessment? Well, you take your existing rooms and you get your facility floor plans out with your safety team, and you consider the square footage of single rooms and double rooms, and you assess which of those you could add a bed or a cot to and still meet your life safety guidelines. And you estimate the increase in the capacity from that assessment. Next, you look at your non-sleeping areas. And using, again, the life safety guidelines, taking into consideration your access and egress points, you apply those space requirements on the floor plans, and you can come up with an assessment of how many beds or cots you could get in that space. This is an example. Ensure all surge bed arrangements will be free of impeding egress or access. Maintain 3 feet between beds. Adjust as necessary if using cots. Maintain 4-foot egress paths to the exit or access corridor. Maintain 1.5 to 2 feet between the perimeter wall and the side of the bed. The area must be free around red plugs, and include privacy dividers between beds, cots, etc. This is an example of how you would work with a floor plan in a non-sleeping area. And you would look at your square footage, you would note your access doors, you would note your closet space, and then your size of beds or cots that you'd be using, keeping in mind the required amount of space between walls and between the beds or cots. And you'd be able to estimate the optimum number of persons that you would be able to care for in that space using beds and cots. You would note that then in your emergency plan. So our suggestions are that you're able to document contingency surge by identifying in advance the numbers of rooms with specific room numbers that you can move from a single to a double or expand from a double to a triple, again, meeting all the life safety guidelines, as well as looking at those non-sleeping spaces, and make copies of all that to justify that part of your contingency surge plan and your crisis surge plan, so that when you are notifying the licensing entity, you're able to simply attach those documents with your surge agreement and let the licensing entity know that you have justification for the decisions you made. Now, the primary agencies to work with for long-term care surge, at least in Kentucky, include our Office of Inspector General, the Kentucky Long-Term Care Ombudsman Program, Kentucky Long-Term Care Facilities themselves, Kentucky Emergency Management at the county level, at the regional level, and at the state level, the Kentucky Department for Public Health, which administers the Hospital Preparedness Program, as well as has the jurisdiction for Emergency Support Function number 8 under FEMA, and then Kentucky Emergency Medical Services. All of these partners are also critical to your mass casualty planning. In the last 2 years, most of the state's departments for public health have undertaken mass casualty planning. And by that I mean, should there be a 16-car or 60-car and truck pileup in winter on a highway in Iowa or in Colorado, all of a sudden there is a surge of newly injured persons, and they are being distributed to hospitals and sometimes even long-term care in an area. And statewide planning determines at what level events move from county jurisdiction up to state jurisdiction. What are the key partners in that mass casualty plan? One of the most critical, obviously, is your Board of Emergency Medical Services, as well as the Department for Public Health. Again, the Long-Term Care Ombudsman Program, if long-term care folks are evacuated due to whatever the mass casualty event is. And in terms of patient tracking, the role of the Ombudsman in reuniting families and being able to track residents in evacuations. State hospital preparedness programs and state emergency management. Now, partnerships that lead to additional funding, in our experience, have come out of the fact that all emergencies start local. It's a whole lot easier to create your initial core of partners and emergency network from, number one, your immediate county and your neighborhood within that county. What healthcare facilities are your immediate neighbors and which ones are your partners within that county, again, and then expand beyond that to a regional makeup similar to, say, an area development district as we have in Kentucky. And we find that there are so many similarities in emergency preparedness between hospitals and long-term care that it's a natural partnership. Then we have found that the Home Health Care State Association has worked with us to revise our long-term care preparedness manual so that it's applicable to home health companies. We've done the same thing and partnered with the Kentucky Assisted Living Association, and they have adopted our Kentucky Long-Term Care Emergency Preparedness Manual. Then we have partnered with all of the coalition partners related to the Hospital Preparedness Program, natural partners at state agencies, including the Area Agency on Aging, the Office of Inspector General, the Ombudsman, as well as local jurisdictions, such as your county resources. There are a number of long-term care in one region in Kentucky that went to their county legislators and had a major meeting with them with 10 long-term care, posing the challenges that those long-term care faced in a rural area in terms of adequate response with emergency generators, emergency beds, emergency supplies, and requesting funding. And we're successful in receiving funding from their county judges and their mayors and county legislators or state legislators. And that right now is one of the most prepared counties in the state, in my opinion. You want to expand your target groups beyond any natural network. You'd be amazed. We have worked with the faith-based entities. We've worked with block watch groups to establish neighborhood networks. And we've also learned what those partners are doing as potential resources, say with the churches or community centers, in terms of being evacuation sites or being willing to assist with transportation resources. These new partnerships have also enabled long-term care and our emergency preparedness for aging program to create capacity to respond to some new ideas that have come out of civil money penalty funding at the state level with CMS and additional funding opportunities. We find that we create new products almost every year as a result of working with such a broad range of partners, and each of those have created new funding opportunities. So it certainly is never a static effort nor a static relationship. One of the things that we have learned over and over again is it takes a community to be resilient. And whom we serve is just as resourceful, even given certain barriers that they might have. But residents in long-term care facilities have volunteered to be actors in mock evacuation drills. They have, neighbors have been willing to participate in those drills. We had one facility that was doing a test run, a drill of evacuation chairs with all of their staff, and they were able to negotiate support from the local transportation company that literally brought a city bus to the facility, and the long-term care facility trained every single one of their staff that afternoon, loading the evacuation chairs onto the buses. And each staff person had to be a carrier of an evacuation chair, as well as had to be the resident on the evacuation chair. And by the end of that exercise, staff's height increased by about 2 inches for each one of them because they felt so empowered. They weren't overwhelmed by the process and felt ready to undergo this type of an evacuation in the event of an emergency. So don't underestimate the value of what you do, how you do it, and those whom you serve. I want to thank Stanford for the opportunity to participate in their webinar series. We are very happy to have that partnership, and I welcome any questions or feedback or requests for our resources from any of our listeners. And here is my contact information. Feel free to call me or email me at the University of Louisville. And thank you very much. Stay safe out there. Bye.